On behalf of the Patient Safety Authority, I would like to welcome you to this webinar titled, What's in Your Endoscopes? A Facility's Journey with Endoscope Reprocessing and Strategies for Reprocessing Effectiveness. My name is Joanne Atkins, and I will be your moderator for this program. Now, I would like to introduce our speakers for the webinar. Christine Bingman is an infection preventionist for the Patient Safety Authority. In this role, she is responsible for education and outreach for infection preventionists at all levels of healthcare. Christine has clinical infection prevention experience as an infection preventionist and a manager of infection prevention for a large health system, as well as a director of infection prevention in acute care, behavioral health, long-term care, hospital-based clinics, ambulatory surgery sites, and long-term acute care facilities. Her clinical experiences enable her to assist others in setting priorities for patient safety and to serve as a content expert in developing infection prevention strategies and solutions for our healthcare partners. Dr. Mohamed Yassin is an associate professor of medicine, infectious diseases, and microbiology at the School of Medicine and Public Health at the University of Pittsburgh. He has been in the role of Medical Director of Infection Prevention and Hospital Epidemiologist for over 10 years. He has over 50 publications and 100 scientific abstracts. He has a particular interest in endoscopic disinfection. He had an oral abstract at APIC 2022 on borescope examination and microbiologic culture that won the Bill Rotella Award for Best Abstract. Dr. Yassin has won multiple teaching awards and has been an invited speaker for multiple national and international scientific meetings. Christine, I will now turn the program over to you.
Thank you, Joanne, and I welcome those who are participating in this webinar today. Neither Dr. Yassin or myself have anything to disclose. The objectives for this webinar are to list potential endoscope reprocessing and storage failures, to describe a tertiary care facility surveillance strategies to assess bacterial bioburden and process improvement efforts, describe recommendations and strategies to measure the effectiveness of endoscope reprocessing and set internal level benchmarking. So with that, we're going to take a moment to review the process for reprocessing instruments. There are many, many steps required to reprocess endoscopes, which potentially can lead to process failures if not done correctly. In order to prevent these process failures, it is important to follow the manufacturer's instructions for use and ensure that all members of the healthcare team understand their role in the chain of endoscope reprocessing procedures. This can be accomplished through competencies and return demonstrations at the time of hire, annually, and as needed. Competency verification must be documented, and it is beneficial to make use of your endoscope manufacturer's education teams to provide hands-on training. Literature has cited that there are specific standards. If you follow those standards, you will end up without any adverse events. Larson et al. Has stated that standards for reprocessing duodenoscopes in high-level disinfection recommends following those cleaning steps, including pre-cleaning at the point of use, leak testing, manual cleaning, drying, inspection, etc. We are aware that in 2015, the Food and Drug Administration published the first duodenoscope related safety communication, which stated the design of the duodenoscope may impede effective cleaning. and therefore lead to the potential transmission of microorganisms in the patient, and therefore lead to potential transmission of microorganisms to the patient. We are also aware that in the late 2021, Association for the Advancement of Medical Instrumentation came out with revised standards for us to use, and also pointed out the importance, or continues the evidence to show that these changes are instrumental in preventing adverse events with patients. So just a little bit about the anatomy of rigid endoscopes. This is a device that has minimal flexing of the shaft that can be damaged if the scope is flexed beyond its limits. It can be video or non-video. It could have a video chip mounted at the distal end of the scope, and sizes range from 1.9 millimeters to 15 millimeters. Fiber optics are housed between the inner and outer tubes and transmit light from the light post to the distal end of the endoscope. And these endoscopes are used to perform surgery and can have a working channel that allows the surgeon to pass instruments. So when we look at the flexible scopes, they are a very complex device. There is considerable complexity to the scope itself, as well as the operators, and there are control knobs that allow the distal end of the endoscope shaft to move up and down. They have small diameters. You can move left to right, and again, changes in diameter. These devices may have fiber optic or video capabilities, and this defined by how the image is captured and transmitted. So fiber optic gathers an image via a series of lenses at the distal end of the endoscope. The image is transmitted to the eyepiece via fiber optic bundle. The video requires you to have a power source and a video system to view the image. So this is like your TV monitor type screen. The image is captured and transmitted as an electrical signal to the viewing monitor. Flexible endoscope lengths can range from 36 inches to 60 inches. And when you view this image, you can see that there are many, many opportunities for miscleaning, decontamination, etc. Just lots of nooks and crannies that microorganisms can settle in. So what are the types of endoscope-related infections? So endogenous, and this is really related to the procedure, and this is all about the clinical soil, the soil that is coming from the individual themselves is having the procedure done. And then exogenous, this is related to the endoscope. So this would be related to maybe ineffectual drying or ineffectual cleaning, storage, etc. Factors that will contribute to the scope harboring microorganisms, enabling them to multiply and then potentially infect a patient. So contributing factors for contamination, there's lots of literature out there to demonstrate failures in processes related to endoscopes. Moisture, retained debris. This retained debris could be proteinaceous material, stents, balloons, cleaning brushes, and other material. Scope damage, and this could be related to, the shelf life of that device. How long has it been in service? How has it been maintained? Is there a breakdown within the scope itself that maybe warrant it coming to the end of use. Other factors include automated endoscope reprocessing, or AERs, and then following instructions for use. And this would be specific to dilution of water, filters on the machines, the accurate and preciseness needed to ensure that the dilution, the chemicals being used, etc., are at the manufacturer's recommendations. And then there's human factors. Human factors specific to the individuals performing the task of cleaning, high-level disinfection, or sterilization of the scope. Maybe a lack of recent education, maybe a lack of staffing, and this would be a leadership issue, not having appropriate staff to adequately process scopes to meet the rate of use within your organization. So again, moisture retention. This is definitely one of the big patient safety issues. Microbial growth is phenomenal. Many of you know that bacteria can double every 20 to 30 minutes. So if you only have one or two, microorganisms at the end of your drying process, there is an opportunity for those to multiply very quickly. Drying scopes prior to storing is an essential part of the reprocessing cycle to prevent the development of microbacterial growth and any type of biofilm formation, and if it's not done correctly, can lead to persistent contamination. Scope drying typically includes alcohol flushes and air purging, usually on a 10-minute pressure rate regulated cycle as per the manufacturer's recommendations. Dry sampling of channels and distal ends of scopes can enable an individual to identify the presence of bacterial contamination. Ofsted et al. Has written several articles on the benefits of following best practices for reprocessing, drying, and storage practices. They completed a study in 2018 and looked at 3 different hospitals. The researchers performed visual examinations and tests to detect fluid and contamination. Fluid was detected in 22 of the 45 endoscopes, and ATP levels were elevated in 22% of those endoscopes, and microbial growth was detected in 71% of those endoscopes. So this just shows that, scope drying is absolutely crucial. There are medical grade forced air pressure devices that allow you to reach that threshold that's recommended for drying. So again, assessing the dryness of a large diameter channel can be accomplished by paper indicators or borescopes. So this is something to consider. Standard cabinet and hanging. And so there are newer devices out there where you have HEPA filtered ultraviolet light type devices, cabinets that are available to hang your endoscopes in. And as we go through this presentation, we'll share more information about those cabinets. So retain soil, again, that proteinaceous debris, brush tips, the adjuncts that are used to perform the procedure, and then the simethicone containing fluid. And simethicone containing fluid is a lubricant used for ease of scoping a patient, but this has negative impacts on the device as it is not, it's a non-water soluble additive, and so it's very difficult to remove the simethicone. Then there's the automated endoscope reprocessing, and again, to focus on that solution dilution, the filters that are associated with these devices, and making sure that they're changed regularly, and contaminated rinse waters. Probably the biggest area or opportunity is focusing on human factors. These influence work behaviors. And so the World Health Organization describes human factor and ergonomics as the study of the factors that make it easier to do the work in the right way. So understanding and applying a human factors approach in the health setting can enhance your delivery of care. In addition, using ergonomics can contribute to improved patient safety when a job and workflow are studied. And when considering the role of equipment reprocessing, one must take into consideration the organization, the individual, and the role itself. So with this, when you consider the organization, do we have enough resources, or is there enough trained manpower? Do we have organizational culture of safety? Are the leadership engaged? Do the staff feel comfortable communicating with leadership that there is a potential problem with reprocessing? For the individual that's actually performing the task, their level of competency and their skills. Do they understand the risk of not performing these tasks correctly, the implications, the fallout if a dirty scope is introduced to a patient? And then the role itself. We know that endoscope reprocessing is a very complex task. And then if you're also responsible for other central processing tasks, the workload and the workflow can contribute to incomplete reprocessing cycles. So now I would like to turn it over to Dr. Yassin so he can share with you his organization's journey with endoscope reprocessing.
Thank you so much, Christine. And I appreciate your wonderful layout of all the preventive effort. And I would like to move from the general big picture that Christine made into focusing on some of the details that I thought is going to be very helpful for everyone. During my talk, I'm going to focus heavily on the clinical aspects that every infection prevention department will be capable of doing themselves or knowing, understanding exactly what needed to be done. There will be two smaller points that I will point out that probably you would need help to get that to a reference lab or a research lab. So the issue here, the first question is, how do we detect endoscope-related infection? Unfortunately, most of the data we know about endoscope-related infections are from the reported outbreaks. And these outbreaks, in my mind, are the tip of the iceberg. But if we're looking at how can we find out truly scientifically, first we should think of clinical suspicion, obviously clusters or outbreaks. So that means when we get 2 or 3 cases of Klebsiella pneumo in the blood, we should think that endoscope could be part of that. look through the records and see how many of those patients had no evidence of explained gram-negative bacteremia, for example, and how many of them had an endoscope of some sort. That would be very helpful. Another way to do that is actually to culture the endoscope itself, and certainly tying the molecular epidemiology data to the electronic health records and saying, if I have 5 pathogens of, let's say, carbapenem-resistant Enterobacteriaceae, CRE, and having these 5 people end up having an endoscope, and within a few days, they got this bloodstream infection, that would be, to me, a link that we could actually do a sequence of these isolates and know that they come from a common source. And that way I could confirm an outbreak or a cluster. But generally speaking, we're more interested in preventing every case, not the weird outbreak, but rather prevent what I would call endemic spread. The second layer that we should think of is what I alluded before, which is clinical surveillance, which look for either patient who developed sepsis after an endoscope, or people who had positive blood culture, as we do in our institution, within 30 days after an endoscope. Then we could extend, based on how we could do our lab testing, from sterile site like blood into urine in case of urology scopes, or bronch, we do a sputum or respiratory culture, and so on. Very helpful parts that I would also talk about briefly is looking at the scope as history. The older the scope, the more repair, the major repair fixing for the scope, probably the higher risk that there's something ongoing with this scope. So you can always ask to get the repair history of the scope. This data is available through the company, and infection prevention could easily get access to that. In our institution, we do routine endoscope cultures, and we do boroscope. We do not do ATP, but I would say it's possibly helpful as well. So this is the diagram that Christine used earlier of a reprocessing cycle. And this is where I'm going to focus on the blue. And as you can see, it's really nice diagram that Christine put. Complex. We really respect the processing of scopes very well, and we made a lot of improvement in the process, no question. But still, the final end product is not tested, meaning we don't know. We know almost everything about the process, but we don't know much about the product. So we do drying cycle, as Christine said. We push alcohol, we push air, but we're really not certain if the scope is dry or not. And we do visual inspection for the outside of the scope, looking for dents, for any mechanical issues, but we actually don't know what's inside the scope. So I'm going to be focused on these 2 specific points specifically. This is one of the studies that we did actually a long time ago now, 2017, with our microbiology, infection prevention, and our colleagues from the lab. And at that time, we got a disposable bronchoscope model, and we contaminated them in the lab, and we processed them as any regular scope. And then we examined these scopes by culturing them after processing. And then we saw what is growing inside them. And we tried to make some lessons learned out of that. And here are the lessons on the right side. That delayed processing was really the most important aspect in having a positive culture. The scopes that were processed within 1 hour, all of them were clean. The scopes were actually processed after 4 hours. Significant number of them, we failed in cleaning them. Second is, if you have a scope that's heavily contaminated or delayed processing, you have to work with your endoscopy suite processing to make sure that they soak these scopes in the enzymatic cleaning for a longer period, typically speaking, manufacturer said around 10 minutes, and for heavily contaminated or blood or delayed processing, we're talking about 30 minutes or more. I don't think this is processed that way routinely, but this has to be stressed on for any delay. Second is, we did not find any additional benefit of doing sterilization after high-level disinfection. And in my mind, every infection prevention knows about that, where everybody would say if it wasn't cleaned well, it doesn't really make a difference to put it through the sterilizer or not. So if there is some material retained within the scope, sterilization would not really kill that. Third is, it's very clear to us that the gram-negative bacteria are the main risk for contamination of the scopes. So the first one was actually to look at the processing of the scopes. This particular data also, we tried to do a clinical surveillance, and that is something that any hospital or any facility could do as well, where you could set up through your electronic health records to see who had the endoscopic procedure, had a list of those, had another list of the blood culture that all the infection prevention follow almost every culture within the system. So you could actually combine those and see within 30 days of a procedure who got a positive blood culture. In our institution, as you can see, the rate for blood culture positivity was low. And the majority of those cases were actually unrelated to the endoscope, and this bacteremia was explained by a totally different source. I have to clarify something that Christine also mentioned earlier, that when we talk about an infection after a scope, Christine said that could be endogenous or exogenous. So the positive blood culture does not really prove that this is related to a contaminated scope, but it gives you an idea about the chance of getting an infection after this procedure, and also give you an alarm or a surveillance that you may want to look at those 3 or 4 patients who had these positive blood cultures, because one of them could be an important case related to exogenous scope contamination. We actually did extend this particular study, and we just finished the analysis of the last 2 years, and we have even a lower rate of bacteremia after these scopes. I'm obviously very happy with that, and I'm very, very interested in making sure that, as Christine said, the process works well. So this is what we call endemic transmission or low-level transmission is kept to a minimal or stopped totally. Now, those in the picture are Amy Metzger and Amelia Cardiff, my colleagues from infection prevention, and they're actually standing in the operation room doing a colonoscope culture. And you could see it's a 2-person procedure. And that was before COVID, so they were not wearing masks. Yeah, we had a life before COVID, as you can see. And then she's doing the flushing through the scope, pushing the sterile water. And then we do the brush, which you could see in the right lower corner of the screen that is actually still unopened. And then after brushing through the scope, we do another flush. We collect through the sterile cup, and we subject that to the culture. This process has been validated multiple times and endorsed by the CDC and the FDA. The process is relatively straightforward. The collection definitely can be done by any infection prevention team. And it's really very beneficial to add to the safety of this procedure as well. And these are the next steps. And on the extreme left picture, this is the duodenoscope, and probably same picture would apply to an endoscopic ultrasound as well, but you would see an ultrasound at the tip. But what I'm trying to show you is there is a special brush to brush the elevator channel to make sure we go through that carefully and have an idea if there's any retained pathogens there. But on the two pictures on the right side, this is what we call the Nalgene filter membrane, where you put on the top, you open the cover in the middle picture, pour your water through, hook it up to a simple suction machine, and once you get all the water out, with a sterile forceps, transfer this membrane onto a blood agar plate or whatever plate you'll be using. And this will be incubated for 72 hours to evaluate for any growth. We also did the culture for some years, and this data is relatively old now. This was sent to the American Society of Microbiology in 2019. So our data is much bigger then. And you could see the growth on the membrane or the filter membrane. The overwhelming majority of our cultures, which around 30% had non-specific growth. So you could see one colony of coagulase negative staph or diphtheroids or corynebacterium. During all this time, we only had 2, and you can say 4 pathogens that were important. Specifically, there is one colonoscope that had Stenotrophomonas in it. And this particular colonoscope was sent immediately for the company for repair. And we investigated the patient who had the scope before, and none of them developed any issues. And this is very interesting discussion as well, where we all think, how can we say that the bacteria on the scope is the cause of the infection when the scope goes into a dirty environment? So the scope goes through the colon, and we all know that no matter how you prep the colon is not sterile. And there is a lot of bacteria there. So why this particular bacteria on the scope is causing the disease, and why not so many other ones? I don't think the answer for that question is clear. But we all know that having bacteria, significant organism like gram-negative Staph aureus, Candida on a scope is not a good thing for sure. This is the real life where the information we know about infection related to endoscopes are heavily based on outbreaks. However, we think the infection transmission is more than that. And for these reasons, one is when you have a multi-drug resistant organism, a good infection preventionist could easily spot that I saw 2 of those pathogens within a short duration, and you would start making epidemiological link for sure. However, a normal bread and butter E. coli or Klebsiella may pass relatively easy. Then when we say blood culture surveillance within 30 days to make sure that the patient had any positive blood culture, well, this is not perfect, because not only infection does not have to make it to the bloodstream only. It could be a deep-seated abscess in the abdomen, in the prostate in case of urology, or in the lung in case of bronchoscopes, and so on. So in reality, the blood culture is not perfect, but if you include every culture non-sterile, you're going to have a lot of false positive that you will have a hard time understanding how is that related to the scope. Also, endoscopic culture is definitely a good safety, but I don't think it's 100% sensitive because it could miss some, and definitely not specific because contamination happens and you could be just getting some noise for sure. Finally, this is something that I want you to know that it's available, where whole genome sequence could be deployed, performed. The University of Pittsburgh lab has the capability of doing that for possible hospital-associated infection or endoscope-related infection as well. What we have a lot of experience with is the boroscope, and I'm very excited about this little device, and I do think the technology is relatively cheap, that almost every hospital could do that. The training for this is relatively straightforward and simple, that an average infection preventionist could actually learn about that very quickly and get a lot of useful information that I would like to show you now. But in brief, there's two types of this borescope. You can see it comes with a camera, comes with, actually, it could have an iPad as well that you could even record your video or your pictures as well. And there's two different sizes now. So the one we have is 1.6 millimeter. They made even a smaller or narrower one that you could use as well. Instead of talking about, I want to show you the actual pictures. So you could see going from the top left, A1 till B3. So you could see moisture building up in the endoscope in the top three pictures. And the moisture is obviously, as Christine was saying, is allowing bacteria to regrow, making these gram-negative incidence of infection is definitely high, and is just a problem for assuring that these scopes are sterile. Looking down at the three panels, you could see what we call intimal or lumen injury. Like particularly in B2 picture, you could see a lot of abnormalities seen at the 9 o'clock location. On the next slide here, you could see more mechanical dent and problem. Like looking at C1 on the top left, it's almost like a triangular lumen. That's not how it should be. And in C2, even you could see the dents on the sides really very heavy. And on C3, you see the dent on the bottom, maybe between the position of the clock, maybe 4 to 7 or something like that. On the lower half, D1 to D3, you start seeing these little particles on the tip of the endoscope from the outside. And when you do your borescope, you could see these tiny things at 6 o'clock in the bottom, 8 o'clock in the bottom, and maybe at the top at 2 o'clock. And again, in these three, you see another tiny reddish particle at the position of 10 or 11 o'clock. And these were retained from a device that was used to protect the tip of the endoscope. Now, in the top panels, you see rust in the scopes E1 to E3. You could see in E3 an ulcer at the position of o'clock around 5. And in E2, you see around the top at 12. And in E1, you see extensive rust. We cultured these scopes. We didn't have any positive culture related to them, but for sure, this is not a healthy finding. And there was a lot of reports that normal saline use is very harmful for the stainless steel part of the scopes and should not ever be used. So I'm just making this reminder to everyone that no normal saline should be used on these scopes, and only sterile water should be used if you're flushing or doing anything for these scopes. On the bottom half of the screen, you see how much damage that the layer of the inside of or the inner tube is almost totally dislodged. And that happens when the endoscopist deploy a forceps, open the forceps while it's inside the channel and fraying the whole channel from inside. And now you're asking me, could bacteria stick to that? Could reliable high-level disinfection or sterilization could be achieved? And obviously the answer is no. And now you see this on the top left picture at maybe 10 o'clock. You see this reddish pigment. And we think this is related to the tip protector on the bottom right. And we saw pieces of that inside the bronchoscope. And we felt that would be very harmful to have smaller parts of this sponge going into a patient lung. So we're probably sure that this is not a good thing. Not 100% sure if this is related to an infection, but definitely adds to the complication. And we replaced those with the top tip protected that you see this plastic. So that was a better choice for us And I just wanted to make sure that everyone knows about that as well. Finally, this particular slide, I did not on purpose try to get picture because I don't think it is easy to do on the hospital level. But in brief, we were able to get some of the old non-used scope to be stripped from the outer sheath so we can observe the dryness within those scopes. So when you process the scopes with different cycles, like Christine mentioned at the start about the alcohol purge, we saw the alcohol really didn't do much. And even the drying cycle that the regular machine have didn't do much. The large main channel that you could examine with the boroscope could dry up in a few days or get better, but the smaller channels, we observed these scopes for over a week and they never got dry. So we had worked with our endoscopy colleagues and we made sure that to purchase these smaller device air pump that could actually pump to individual channels and make sure that this gets all the air through these channels and get all the moisture. The endoscope, particularly one of the manufacturer, the Olympus manufacturer, has an additional 10-minute cycle that actually could help a lot with drying the scopes. And when you talk with the endoscopy processing staff, they will tell you that if you're going for a high-level disinfection into sterilization after, the scope has to be dry, because if the scope is not dry, the scope could actually burst and explode during the processing. If you're putting the scope into the hydrogen peroxide or the plasma as it's called, the scope could make very hard crystal inside that could actually harm the patient or the next patient when you use. And definitely any moisture left in will not allow proper sterilization as well. I spoke about this already, and I do have nothing to add to the slide at this moment. My final point is related to the endoscope, the disposable endoscope. And I do think in infection prevention, if anything could be single use, that would be the best possible. However, we know that there's a lot of stuff that cannot be single use. I'm not aware of anybody who goes to the MRI testing and he's the only one who used this MRI and he was the last one. But most likely, these devices we will have to reprocess. Unfortunately, the bronchoscope specifically, the image was not as good as the fiber optic, the one that is reusable. And the ERCP that is linked to a lot of the infection had a recall recently related to intestinal injury. So I bet this will put some hold or delay on the processing of these disposable scopes. And I would turn the microphone back to Christine. Thank you.
Thank you, Dr. Yassin. So this, at the end of last year, Amy released the Standard 91 for an update to the 2015 document that really talks about quality control activities that we can do to improve the reprocessing cycle. So I'm just going to take a few minutes and focus on some things for infection preventionists or endoscopy teams to consider when trying to implement the best practices in your organization. So one of the recommendations is to assess the facility reprocessing by conducting a risk assessment. Visualizing your scopes inside and out, evaluating your endoscope storage. Can you make changes there to ensure that they are dry, maintain cleanliness, etc. To consider strategies to assess for contamination and dryness, and this can be accomplished through ATP, surveillance cultures, etc. and the use of boroscopes, and then also really focusing on staff competencies, looking at your policies and procedures. Have you this year taken your policies and procedures and reviewed them to make sure that they're up to date with the recommendations from AAMI Standard 91? Are your staff using appropriate personal protective equipment and also standard precautions when handling scopes? So HICPAC has graciously provided us all with a risk assessment tool or a gap analysis, and it looks at every aspect of scope reprocessing, so the cleaning, the leak testing, the manual cleaning, really the cycle that I showed you at the beginning of the presentation, looking at storage, looking at documentation, and also, do we have administrative support to, keep those scopes in storage, to maintain an appropriate shelf life, what is a shelf life within your organization, et cetera. And then again, just really focusing on policies and procedures to update. So using this tool, it is a very complete assessment tool, and I strongly recommend that you access this and take a look at your internal program. So endoscope storage. If we put a wet scope back in the cabinet, it's going to grow microorganisms. If that cabinet does not have good ventilation, that it's dry, that it's dust-free, etc., you need to evaluate that cabinet. And again, I shared earlier that there are newer cabinet options available to you. And this is something that as your administrative team is assisting you in developing or evaluating your endoscope storage program, then maybe this is an opportunity to obtain one of those cabinets. There are horizontal and vertical cabinets with ventilation systems, ultraviolet light, etc. So explore those options. Making sure that if you're using an older option, that the endoscope is hanging with the insertion tube hanging vertically without coiling or touching the bottom of that cabinet. And then, not storing the endoscopes with removable parts in places, with the control valves, the distal hoods, caps, etc., because those leaving those things in place can trap moisture. You want to follow manufacturer's instructions for that horizontal storage of flexible endoscopes. I think it's really important that if you're not used to that technology, that your team be educated through the aid of the vendor to understand those products well. And then again, following your organizational policy for a maximum interval of endoscope storage before reprocessing. So we all know that, one organization may say 5 days, another will say 7 days. You as an organization have to decide which standards you're going to use for storage of those scopes and when you would like to reprocess them, and make sure that you're following that policy. ATP surveillance. So this is a multi-step process that requires you flushing sterile water through the endoscope channel or using a swab endoscope service, a test strip to determine the presence of organic material. You need to develop that program. What are you going to assess every single scope that goes through reprocessing, or are you going to have a random selection process for testing? What is the pass-fail threshold for levels of proteinaceous material? Is there standardized methodology for tracking, and then ensuring that you have an adequate endoscope inventory so that you can, you know, if you have cases added, there's not this, you know, overwhelming sense of reprocessing these scopes in such a way that maybe the pre-cleansing, cleansing, decontamination is cut short because of the significant need. Microbiological culturing. So again, something to consider for your organization. Do you want to implement microbiological culturing? The frequency, is this going to be something random, or are you going to routinely conduct microbiological culturing? The CDC and other organizations have available out there procedures for performing surveillance culture, so that may guide you. You want to develop your own institution's culturing protocol. It is a two-step person. There's just no way around it. When you're obtaining samples, you need to maintain an aseptic technique and perform brushing steps. That's for the person that's collecting the specimen. The person that's assisting you is going to handle package opening and endoscope portions that are not sampled. And then you need to have a separate protocol for outbreak investigation cultures. So if you do have an event within your organization where there's a potential outbreak, then there needs to be that separate protocol. Infection prevention personnel are responsible for reviewing endoscope culture reports. And then the cultures, remember that they are not clinical, therefore they are not subject to CLIA oversight or FDA review. Currently, there are no external proficiency testing standards to assess culturing proficiency. So this is something where repeated practice is going to increase the skill set. And then borescope surveillance, what to consider. The surveillance after every endoscope reprocessing, or are you going to perform periodic assessments? You should have some type of a borescope plan with specific and measurable goals. What steps should be taken if defects are identified? Obviously, we know that if there's a defect identified, it's taken out of service and sent back to the company. But what other steps, you know, do you need to consider? Was there exposure to a patient, et cetera? Consider where boroscopy will occur and by whom. So, you know, is this a boroscopy going to be performed by central sterile? Is it going to be performed by infection preventionist or another team? You need to ensure that you have appropriate training, appropriate competencies, and then have very good vendor relations to ensure that you're up to date on latest changes with that company. So I just want to remind you that in the event that you have a patient that has a serious illness, an injury, or a death related to an endoscope procedure, this is a reportable event. And it also is required that you report this to MAUDE, the FDA MAUDE, the Manufacturer and User Facility Device Experience Database. The FDA is tracking these events, and you know, this enables companies and patient safety organizations to identify where these events are occurring, what kind of scopes that they're occurring with, etc. So it is important that you enter the information into the database so that events can be captured and then analyzed and trends identified. So with that, Joanne, I'm going to turn it back over to you.
Thank you, Christine and Dr. Yassin. This concludes the slide presentation portion of our program. Now we would like to begin our question and answer period. There is one question that has come in. How frequently do you recommend auditing endoscope reprocessing practices?
So I think it's really important for infection preventionists to get into the OR endoscope suites to perform audits, to assess the level of comfort with the practices that are set out in your policies and procedures. There is no specific recommendation for a frequency, but there is definitely a need for you to monitor. You always learn something new when you enter into those suites. It may be something very minor, but it could have an impact on outcomes later. So for my personal practice, I think it is a good idea to at least go into those areas a couple of times a year. If you have significant turnover with your staff, or if you have travelers that may be new to your facility, etc., this is a great opportunity just to verify that practices that are being used in your institution are being followed as outlined in your policies and procedures.
Thank you, Christine. We do have another question that has come in. How do you know when an endoscope should be taken out of service permanently?
So the typical scenario that when you send a scope into the company for repair, they usually remove the inner tube and replace that. The inner tube will be what actually goes into the, like anything that goes into the patient, the water, the air, the forceps, any foreign material, any blood, any stool, anything will go through these tubes. So this is all almost 100% of the time gets removed. Any major mechanical problem with the wires or the light, those probably will end up having a permanent repair. Most of the repairs are related to slight perforation of the outside, some not passing leak test. And as I said, those are usually fixed by removing the inner tube and reinforcing the outer tape and stuff like that, and that should take care of it. Thank you.
Thank you. We do have time for another question. This question came in through the Q&A box. We have developed a policy process for culturing of ERCP scopes monthly and PRN. The process is performed by a minimum of 2 endoscopy staff and verified by infection prevention. Are there any other steps that should be added?
So they're using 2 individuals. I can't see the question, so.
It says that there are 2 endoscopy staff that are doing the culturing and it's being verified by infection prevention. This procedure is being done monthly and as needed. And what they were asking, is there any other steps that should be added to that?
Christine, I can comment on that, and please add too, but not all scopes are created equally. Not all procedures are created equally. So if your facility has low risk of complication, relatively shorter procedures, then I think you're fine. If your facility does complicated, longer procedures, as an example, EUS or ERCP could take over an hour, and that would allow even endogenous material to stick into the inside of the scope and increase the risk for infection. So if you're culturing, that's a good thing. Most of these GI endoscopes are sturdy and large. Boroscope examination only revealed the moisture, so you should focus on preventing the moisture by either getting a protocol for the air purge. The cystoscope, the ureteroscope problem is a little bit different, where we see most of the mechanical issues, the dents, the rust. These scopes are kind of more friable. So I would say probably boroscope examination will help you a lot in those. For the bronchoscope, the problem is different, where unfortunately bronchoscopes are done by fellows, residents, and attendings, people with different expertise, and done 24 hours, 7 days a week. So delayed processing, mechanical issues are common. And I would probably think those should be added to your thoughts of either culture, ATP, or boroscope, or the three of them. Please, Christine, comment as well.
I think with the latest AMI standard update, really focusing on what the staff are doing at the point of use. So like Dr. Yassin said, some of these procedures can be very lengthy. And so, you know, are we using pre-cleanse? Are we wiping the device, et cetera, to get rid of that proteinaceous material as much as possible? You know, really focusing on the basics, but the fact that you're culturing is exceptional. That's really great.
Thank you both. We are past time. I want to thank everyone for joining us today. If you experienced any issues accessing the evaluation and/or certificate of continuing education, please feel free to direct any inquiries to Shelley Mixel at shmixell@pa.gov. This concludes our webinar.